Good morning and welcome to our monthly webinar on the Behavioral Health and Criminal Justice Interface Series. We'll get started in just a minute as folks get logged on to the webinar. If you're not familiar with GoToWebinar, I'm going to go quickly through a few housekeeping slides that just explain a little bit more about the platform of GoToWebinar. So it's always a good idea to mute your computer speakers or your microphone. If you want to ask questions, I encourage you to type your questions into the question box or raise your hand and ask the question verbally. But if you do ask the question verbally, it's always a good idea to call in using the audio number provided in the pane on the GoToWebinar menu. So again, we'll get started in just another minute as our folks get logged onto the GoToWebinar platform. And good morning, James. Thank you for joining us this morning. I'm very proud to have our two speakers today from Lourdes, and we'll introduce them in just a minute. All right. So again, let me go through a few housekeeping slides first before we get started. So again, it's really, if you're not familiar with the GoToWebinar, audio is always can be a challenge with some background noise. So really encourage folks to mute your microphone and speakers if you want to ask a question verbally. We can also encourage folks to type your questions into the question box, and we'll get to those at the end of the presentation. We do record these webinars, and we are working at creating a website on the Healthcare Authority site. And so all of these recordings are being recorded, and we have them posted on YouTube. And I will be sending out the slides after the webinar that have the links to all of our previous webinars that we've hosted. Again, if you're not familiar with GoToWebinar, you have a little menu that can be expanded and contracted by the little orange arrow. You should have two choices on the audio menu, either the computer audio or a phone call. If you click on the phone call, it provides you the call-in information in order to be able to connect and ask your question verbally, or you can choose the computer audio and you should be hearing us over your speakers and your microphone. Questions, you should be able to type your questions into the question pane, and we'll be able to get to those at the end of the presentation. There's also a little hand icon. If you want to ask your question verbally, you can raise your hand and I'll call on you and unmute you, and then you can ask your question verbally over the phone. Oops, going the wrong way. It is a little counterintuitive because the little hand icon green is up, or means that your hand is down, and you want to click that when you want to raise it. And then the little red arrow means that your hand is currently up. So why don't we test that and see if folks want, if our audio is sounding nice and clear, if you want to raise your hands. Perfect, seeing some folks raise their hands that our audio sounds good. Awesome, thank you so much. And then go ahead and put those hands down. So we've been doing these webinar series since the first of the year. And really, this webinar series kind of started out because a number of divisions within the Healthcare Authority started coming together, like our Criminal Justice Treatment Account Program Manager, our True Blood projects, the Jail Transition Program Manager, our Medicaid reinstatement program, and we all started coming together to talk about how the different divisions within the Healthcare Authority are working on helping people that are connected to the criminal justice system that have behavioral health conditions. And we decided that we wanted to not only learn more about each other, but also what are all of the different programs that are happening in Washington State. And so we said, let's do a webinar series, and then let's open that webinar series up to the public. And so we've so far, this is our 6th webinar series, and just really thank Gordon very much for volunteering and being willing to do this webinar today to highlight their program. And so this is really exciting to be able to share all of these different programs with you. Again, these links to the previous webinar series will be sent to you after the webinar today. They have all of the links to the previous recordings, and you'll be able to listen if you're interested in any of these specific programs. If you want to hear about a specific program, please shoot me an email. We're always open and looking for new programs to highlight in this series. So happy to take your requests, and we'll do our best to try and get those requests met. So let me start the conversation just a little bit about the jail transition program. The jail transition program, and Gordon's going to go even more in depth into the jail transition program, but we have the statutory authority under Senate Bill 6032, which is our operating budget, where we receive the funds for the jail-based mental health treatment program. And so every year we write a legislative report. I provided the link to the most recent legislative report that sort of summarizes what each region is doing. And over the last state fiscal year, over 12,000 individuals received over 46,000 services under the jail transition program. So each jail transition program in each region is managed by the Behavioral Health Organization, or BHASO, in their region. And so the BHASO's contract with community behavioral health agencies to deliver these services. The BHOs and ASOs contract with the providers to provide services to incarcerated individuals with mental health evaluations, treatment, and intake services. That also includes helping individuals apply for Apple Health and other benefits. So there's a lot of innovative things that our programs do to help people get connected, that bridge from incarceration out into the community. And we're going to hear specifically from one program from Lourdes, and so we have Gordon and Cameron who are going to be presenting today. And Gordon Cable is the Outpatient Services Director. He has over 27 years in community mental health. He's worked in both inpatient and outpatient settings. He received his Master's of Science degree in clinical psychology from Eastern Washington University in 1995. And prior to joining Lourdes' team in 2015, he spent the last 16 years providing crisis work as a designated mental health professional, a DCR. The last 7 years were in a management role. He currently oversees the operation of jail behavioral health, Lourdes Health Crisis Services, mobile outreach team, prosecutorial diversion program, and admitting and support services. He firmly believes in early identification of an individual's needs and providing the right services in the most appropriate setting. And we're also joined by his colleague, Cameron Fordmeyer. Hopefully I pronounced that correctly, Cameron. Cameron is an outpatient manager at Lourdes and directly oversees the crisis services within the Benton County Jail Mental Health Services, the prosecutorial diversion program, and the mobile outreach team. Cameron has 19 years of mental health experience working in a variety of settings, including community protection group homes, psychiatric inpatient units, case management, therapy, and working as a designated crisis responder since 2010. Cameron has experience in program development and assisted with implementing the supported employment program, immediate response counselors, transitions, which is a crisis triage facility, and most recently, the mobile outreach team. In addition to his clinical roles, Cameron is heavily involved in the community and actively serves as the chairperson for the Benton and Franklin County Youth Suicide Prevention Coalition. Cameron is a committee member and instructor for the local crisis intervention team training. He's also an instructor for management of aggressive behavior, mental health first aid, and adjunct professor of the Columbia River Basin. So Cameron and Gordon, thank you so much for your willingness to present today. And I will turn it over to you guys.
All right, thank you, Melody, for the introductions, and we appreciate this opportunity to at least share what we're doing locally at the Counseling Center. We appreciate you hosting these webinars because I think it gives everybody an opportunity to learn about other programs and take pieces of what may work in their local community. So with that being said, what I'll be doing is kind of provide a brief overview of the history, some statistics, and then I will turn it over to Cameron to get more into the operations of our jail behavioral health program. So next slide. Can you advance the slide, Melody?
Yeah, there's just a little bit of a delay, so
okay.
It is advanced, so hopefully.
There we go.
I think we're good.
So for Lourdes Counseling Center, we actually started services about 15 years ago in 2005 as a result of House Bill 1290, which I think was kind of the previous version and the thing that kicked us off prior to the 6032. The initial services, and obviously I wasn't here when that began. I've overseen this program for about 5 years. But they had 2 case managers, a mental health professional, and the primary focus was on benefits and doing those incapacity evaluations. Back in the day, they were called GAU. So it was for a temporary incapacity, and so the mental health professional would actually do the evals. We had a identified individual at our local community services office that we would contact, send the eval to, and then they would make that determination of whether they qualified for those benefits. We also did a lot of the pre-release planning when we initiated the program, and then post-release interim services. So there was a lot of transportation to local housing authorities, to the community service office, to crisis if need be for an evaluation. And so that was the initial program. Since then, the program's evolved and continued to evolve, and it's really based on the need of the jail. And we've been fortunate, and Cameron will talk more about it, that our local command staff and leaders of the jail, have bought into the idea that behavioral health, is a real and serious condition, and that we can do better with treating individuals that have to be in jail, identifying individuals that may be served better in a different population. And so, as our program evolves, it's evolved kind of in step with command staff and talking about what the jail's needs are. So currently we have 2 mental health professionals. We have 1 case manager. I've got 1 part-time peer listed. We're currently recruiting for that position, and that's, speaking of the evolution of the program, that's something that we just recently changed. We used to have, the 1 full-time case manager and 1 part-time case manager. And when the case manager retired, we had a conversation with the jail staff, and through Cameron and I's experience with our mobile outreach team and our prosecutorial diversion team, our PAC program, and the peers that were part of that program and the successes we saw with those peers, we thought that adding a peer, and I'd love to have a full-time peer in the jail, but right now the budget only supports a half-time, but adding a peer, somebody with lived experience that could connect to people in a way that your typical professional may not be able to, would be of great benefit. And so we're anticipating good results with the addition of that part-time peer. We also have a part-time psychiatric prescriber. They're there 3 days a week with the goal on using that specialized skill set to identify inmates who may need some type of psychotropic intervention and seeing them and getting them on the right medications. Cameron will talk more in detail about it, but what kind of precipitated that was what historically the jail saw was that everybody that went to jail had anxiety, which makes sense. If I went to jail, I'd have anxiety, and had sleep problems, which again makes sense if you're in jail. Probably not the most conducive environment to good sleep, and so a lot of folks were requesting benzodiazepines and sleep medications, and their budget for those medications was going through the roof, and so they made a decision that they didn't have the expertise in there to tease out who really needed the medications and who wanted to just kind of sleep their time away while they're in jail, and so we started that program a few years ago. The focus now, we do everything that we initially did with the benefits. Obviously, that's changed now. It's more determining who their MCO was if they have Medicaid or if they have private insurance, and then making sure that their insurance is active on the day of their release, and then coordinating services for that individual. But a large part of what our job is, and again, Cameron will talk more in detail about this, is evaluating risk of the inmates. So everybody that comes in through the door of the Benton County Jail, and they're fortunate to have medical there 24/7, has a medical screening, which includes a behavioral health screening. There are certain criteria if they screen positive for certain mental health symptoms or behavioral health symptoms, that they're held downstairs and a request for one of the mental health professionals to do a full evaluation, determine risk, make custody management recommendations and treatment recommendations. So every individual that's screened positive for that is seen by one of our mental health professionals. A large focus is on diversion. As soon as we can, we have a couple, programs early on that we hope to keep people out of jail from the start, but that's not always possible. And so, part of our goal is to identify those individuals that would be better served in a behavioral health environment, and then working with command staff and the court personnel on figuring out what the next step is to get them out of jail into the right environment. We have begun providing more treatment, like we had talked about with the medication piece. If somebody is reporting problems sleeping or high anxiety, we'll have one of our mental health professionals or case managers meet with them, can work with them on coping skills, good sleep hygiene, and have them work on that to determine whether or not that's something that will be beneficial or help them, and hopefully avoid having to have them take medications for those. Again, we still do the pre-release planning, post-release interim services, which is, I think, critical because I know, prior to implementing this program, what would happen is you'd see people in jail, they'd have a behavioral health need, they'd walk out the door, maybe with a card for a local treatment provider and be told to follow up. And probably many of you on this call can predict what the percentage of follow through was with those individuals. It was close to 0%. The system's difficult to navigate, and so I think if you have somebody to continue motivating you, which is I think why we're excited about the peer position, because we're going to task them with doing a lot of that follow up and engagement and motivation. But somebody to walk alongside with you, continue to encourage you to get the help, help problem solve and navigate through any barriers to accessing treatment, and then getting you to at least that first intake appointment where, you know, if you qualify it, then you can have a case manager assigned to you that does a lot of the things that we're talking about. We've also, you know, we've been fortunate to have Cameron who gets rave reviews with regards to his training of correction staff, and he'll talk about the mental health first aid trainings that he provided, and then in the Benton County Jail, they request ongoing Kelly trainings, which is days off for correction staff that they are mandated for trainings. And so I think it's about 8 hours a year. So about twice a year, either Karen, myself, or one of our jail mental health team will provide a training specific to behavioral health to all correction staff. We also participate in their multidisciplinary team meetings and develop care plans for individuals with more complex behavioral health needs. And again, Cameron will talk more in detail about those. Next slide, please.
There's just a little bit of a delay on the transition of the slide, so it's coming.
Okay, thank you.
Honestly, it's coming.
I believe you. Maybe I'll insert next slide as I'm in talking about the current subject about 30 seconds beforehand. There we go. So for our program, I'll talk a little bit about the funding, and I know Melody had touched on it. So there's obviously been multiple changes, you know, over the last decade plus. So we received the funding, as Melody said. It went from the state to, for us, Greater Columbia Behavioral Health was our RSN, which changed to a BHO, which is now an ASO. And I think it was probably 6 or 7 years ago, there was significant reductions in the funding. And for us, it was roughly a 50% reduction of the funds, which we were able to manage, you know, up until 2019 by utilizing Eastern State Hospital saving dollars. And I'll briefly explain what those were to the best of my abilities. Is the state hospital on our side of the mountains, we had, for each RSN or BHO, they had a bed allotment of how many individuals could be sent to the state hospital for that longer term care. And if you went over your bed allotment, essentially you were renting beds from other places that were under, and so you had to pay penalty dollars to them. And so in our region, thanks to, you know, creating the hospital liaisons, which, you know, would go up to Eastern and help with discharge planning, our numbers were historically low, so we were well under where other regions were over. And so, you know, annually we would receive large chunks of money at our RSN BHO that the funding and fiscal team decided that we would use that for the jail behavioral health programs. Because those dollars were flexible, and as people know or may not know, you can't use Medicaid money to provide services in the jail because Medicaid is now suspended when you're in the jail. And so you need those flexible dollars to provide those types of services in the jail. And so essentially what we would do would be backfill our shortages with those penalty dollars so that we can continue providing the services as we had historically done. There was also some hospital saving dollars, which it's kind of a complicated process, but locally we would withhold money in anticipation of what we thought our state-only dollars would be for our hospital, and if we were under that, we could use that for other services like our jail behavioral health program. Those went away in 2019, And so those alternative funding sources that allowed us to kind of keep our program whole disappeared. In 2017, prior to that, we contracted with the county to provide that prescriber for the reasons we talked about. And I believe it's from it's called millage money. So it's mental health, developmental disability tax money that goes to our local human services. And so we worked with the administrator of that department and was able to secure funding, ongoing funding for our prescriber. Our contract with Benton County to maintain the staffing began in 2019, and so they made up that shortfall, and that was done through our local public safety tax, which was approved by the voters, probably 4 years ago, and it's a 0.3% used for various public safety purposes, and so they were able to secure some of that funding to maintain our current level of staffing. Cameron and I had talked about this, obviously, and with the jail staff. We certainly would like to expand the program further. We'd like to add a DCR because currently our staffing model is Monday through Friday, roughly from 7 a.m. to 6 p.m. We'd like to be able to have a weekend designated crisis responder to meet those service needs throughout the weekend and be able to provide 7-day-a-week coverage, because currently the way it works is correction staff are tasked with kind of making those decisions, and while they had some training and they do a good job of it, they don't have that same level of expertise. We would like to add a substance use disorder professional so that we would have the full complement of services. We'd have peer services, we'd have a psychiatric prescriber, we would have the mental health professional DCR, and we would have an SUDP that can consult with corrections staff, with our staff, complete assessments, and help navigate that side of things for individuals. You could probably click next slide as I talk about this next one, Melody. And I'm not sure if it's on the next slide, but as most people probably know, a very large percentage of inmates or people with behavioral health conditions also have a concurrent substance use disorder as well. And so we really felt that having the substance use disorder professional would be beneficial to the team and to the individuals being served in the jail.
So on my screen, I do have it as the next, but I see it's still not showing up. So it's coming.
Okay, and there it is.
There we go.
So for Benton County, our local jail has an average, and this is pre-COVID numbers. Obviously, I think across the state and the nation, there's been a significant impact with regards to the pandemic. So these are pre-pandemic numbers, but they had an inmate count of approximately 550 individuals with a max capacity of 744. A report by DSHS in 2016 indicated that back in 2013, 78% of folks with Medicaid DSHS clients booked into the Benton County Jail had some form of behavioral health need, and anecdotally we see that as well. Other studies have consistently shown that between 10 and 25% suffer from a serious mental illness, whether that be a mood disorder, a psychotic disorder, or another disorder. Next slide. So for our program, we saw an increase of 178% in the number of services provided. by the team from 2014 to 2019, and a 20% increase in the last year. Oh, can you go back one?
It's a little persnickety.
And I think, you know, what has precipitated that increase is again, you know, the changing culture by correction staff, by law enforcement in general, and by jail medical on being able to identify those who may have a behavioral health need. I think we have a long way to go, but, you know, obviously decrease in stigma associated with behavioral health conditions, and so I think we're seeing more inmates use the kiosk or request mental health services than we have in the past, and so I think those numbers will continue to increase. Last year we provided 3,689 services, which is a combination of those pre-release, post-release, interim case management services, and then the evaluations in the jail, and then all the stuff that Cameron will talk about here shortly. About 144 unduplicated individuals receive services monthly, and so that's roughly 25% of the jail population, which is kind of consistent with the statistics that you saw on the previous slide, that, you know, anywhere from 10 to 25% of individuals incarcerated at any given time suffer from a serious mental disorder that will require some type of intervention. And so, you know, our focus is on those individuals, but anybody that requests services, even if it is for some lower level anxiety, we will try to work with them on coping skills. And then again, you know, from the moment we've identified them, we'll work on that pre-release planning and make determinations whether or not they can benefit and are interested in ongoing behavioral health services, whether that be substance use, mental health, or co-occurring services. In the last 12 months, and this is something that we've improved on over the last few years, and again, it's that shifting of the culture. We've been able to work with command staff and then with the local courts, prosecutors, defense, and judges on facilitating of the release over 25 inmates to participate in some type of diversion program. I'll let Cameron go into detail about those programs, but those are such things as if somebody's incarcerated and is acutely psychotic and is decompensating, because again, the jail is not the most conducive environment for somebody with behavioral health conditions, and so oftentimes those are exacerbated in jail, even with appropriate services in jail. We can facilitate, you know, either the release or the furlough of that individual to a psychiatric facility or crisis triage facility where they can get stabilized, and then if the crime is such that they need to return to jail, they can return to jail. If not, you know, there's other options available for them for ongoing treatment. Next slide. And those, going back to the previous slide, just real briefly, those numbers are individuals that, if not for the jail behavioral health team, would have remained incarcerated. They don't include, and like I said, the culture has shifted locally, where, you know, if the jail behavioral health team hasn't seen somebody or hasn't identified them, and they go to court and the judge notices there's some obvious serious behavioral health concerns, the judge, you know, at that time can request that they be released. Again, our focus locally, especially in the last couple of years, especially for the lower level crimes, is to try to avoid the competency route. And I won't go into a whole lot of detail because that's not what this webinar is about. But rather than have somebody, you know, have a competency eval and go to Eastern State to be restored for competency so that they can remain in jail and have the charges adjudicated, if it appears they have serious behavioral health needs, we'd rather just get them to the right environment to treat those behavioral health needs, and again, utilize some of the diversion programs we have so that they don't get stuck in the judicial system. With that being said, I'll turn it over to Cameron to kind of talk about the day-to-day operations.
Thank you, Gordon. Good morning, this is Cameron Fordmeyer. And so talking about a routine day, there isn't really a routine day in jail because it always changes, it's always evolving, and the population as well is always a little bit different with different challenges, but we'll do our best to sum up a typical day for our mental health professionals and case managers. So coming on, they will receive a list, and that list usually has people who have either initially been arrested and flagged, maybe they made some suicidal statements, maybe they were unresponsive or slurred speech or any reason to kind of red flag that there was a mental health concern or a severe substance use disorder concern. And so they'll receive those card watches, and the card watches will typically have what observation they were on. Were they in holding? Are they on a continuous watch? Are they on a 15-minute watch, 30-minute watch? Are they in the observation cell, safety cell, etc.? So we will look at the initial reason on why that card watch was put on, and then kind of prioritize on who is in need to be seen the soonest. And so they'll take a look at those, staff those with either the sergeant or whoever has the highest rank on shift, and we'll go through those and prioritize on who needs to be seen first and who is seeing what patient. We'll try to match people up based on who's the best fit for them, and whether that's the population that they work the best with, or whether that is another issue of monolingual, or whether that's a issue with being male or female. So we'll try our best to match the mental health professional or case manager with the specific population, but if we can't, we'll see anybody and everybody. So then they participate in a morning Mdt briefing, which is a little bit different than our Mdt meeting. And so morning Mdt, they will go over what happened from previous shifts. They'll go over who's got what court date, what is there, maybe like Gordon touched on, is there a furlough order, is there a PR order, was there any issues with medical, and ideally we would have, currently we are Monday through Friday. Ideally we would be Sunday through Saturday and up into the nights and weekends, and so there's a lot that can happen over the weekend or during the night, and so those are usually the times that we'll get those reports and talk about those issues. So after the Mdt meeting and they kind of staff those out, they'll go on with their day. Part of that is going to be to complete assessments and make those recommendations. And so we are guests in the jail. It is the jail, so we are very clear that we are making recommendations. We are not telling the inmates what to do or how they'll progress, and we're not telling the jail what to do, and we are just making our recommendations. And so if there is a bigger issue that the jail, whether that's due to policy or whether that's due to past history on why there may be some difference in opinions, we will defer to the jail. But our recommendations are going to be based off of safety and self-report and observations of that inmate. And so we may change the continuous watch to a 15 and try to work that way up to a 30 and have some natural progression there. Or we may say that, they were under the influence, they're not showing any signs and symptoms of needing any type of monitoring or CWAL protocol or any other type, and so defer to medical, verify that, and then maybe kick them back upstairs to general population or work our way up depending on the situation. So the MHPs will typically complete that assessment where the case manager is ongoing and following up with the inmates. So the MHP there will make those determinations. They will also review and respond to requests from behavioral health services where that's the MHPs can do that, but typically our case manager, will do those. And so the system that we have in Benton County is we refer to them as a kite. And so the inmates will either one request they need to be seen for a variety of behavioral health reasons, or that they have a recommendation that they want to help with post-planning. There may be some concerns with medication, that the medication's not working, and so they have a system where they can make those requests or reports, and we'll have somebody follow up with them wherever they're at in the jail, whether they're in booking, holding, or up in one of the tiers there. We can also, during any of those times, so whether that's the individual that we saw in holding that's on a card watch, or whether that's somebody who is up in one of the tiers already, if there is a specific reason that we're worried about release or we're worried about their current state, they can place a mental health hold or a crisis hold on them. And so how we differentiate the two is mental health hold would be, we would hopefully be able to handle that internally. If it's a crisis hold where we're thinking that the person may need to be evaluated under ITA law, or maybe secure detox is where we think they need to be headed, or something, we can flag that to where crisis will come in, and the designated crisis responder will do that evaluation either with the furlough order while they're in custody or with the PR after they've been released. So we make sure that that person isn't just going to get released during the night and then be out and with no post-planning or no further follow-up, or potentially being in a psychiatric hospital or secure detox facility. We are also, during that time, continuously screening for potential diversion options. If we see a common trend that this individual, for example, had no prior history, they didn't have a long rap sheet, a long criminal history, but we have had word that they started using meth or they started using different substances, and now they're returning in and out of jail, that may be a good candidate for for the drug court. Same with individuals who are requiring 1077 competency restoration orders continuously. They meet some of the requirements based on, or I should say, exclusionary crimes, so that they committed low-level crimes. We may be looking at mental health court or the prosecutor diversion program, depending on those criminal offenses or the type of population. And so if we can, Gordon touched on that, right services, right time. If we can get somebody who would be better suited and their criminal charges are primarily due to severe substance use or their chronic mental illness, and we see it all the time, there's tons of trespass charges, disorderly conducts, things that you or I, if we committed, would be out of there the next day, where these individuals need to have competency or restoration orders, and they're in there for potential months, and that kind of touches on the true blood and some of the other content dollars that were there. We want to get those individuals out and placed in a more therapeutic environment that we can stabilize them to where those criminal issues wouldn't be there if they were in treatment or they were stabilized on medication or in some type of form of treatment. Again, we're going to complete those gains. We have the checklist that identifies individuals either currently in jail, what those needs are, or also the pre-release planning. We don't want to have a revolving door, and I don't think anybody wants that in the community or internally within the jail, let alone the mental health system. We want to set up a plan for somebody who's going to succeed. And so whether that's in housing, whether that's substance use, whether those are benefits, whatever that need is, we are going to come up with a pre-release plan and get the inmate on board with that as well, so that hopefully we can get these places and these barriers put in place to where it's not a revolving door and they're not coming back, and they have a likelihood to succeed because maybe primarily those are due to homeless issues, and all of their criminal offenses are revolving around the challenges of being homeless or their substance use issues or whatever those issues may be. We really want to put a wraparound program around that person and get them connected to the services that they need. One of the kind of caveats to the program is that we have a post-release interim case management. And so as we kind of touched on and talked about with that suspended of benefits, they may not be able to return back and get right away into a med provider or get right back into there. And so we may have to provide some post-release case management and get them hooked up with their benefits, take them down to the Social Security office, wherever that is that they need to go, get them involved in their intake and transport to that intake, wherever it would be that we can basically provide some quick services till they can get more permanent services attached to them. We will do that. And we touched on this before with the briefly Mdt meetings. We also have, and you could probably go ahead and switch the slide while I talk about the weekly Mdt meetings. The weekly Mdt meetings I'm a big fan of because they are very eclectic. There isn't a one-size-fit-all model for anyone, let alone for inmates. And so if we are approaching this just from a clinical standpoint and not taking into account all the various disciplines that go into, or at least have contact with the individual, we're doing a disservice. And so part of that, as you can see now with those jail Mdt meetings, we will sit down, everybody will have their piece or what they've observed or what contact they've had with the inmates, and these are high utilizers, I think is the most appropriate way to say. So we don't do Mdt meetings on every single inmate, but we will if that inmate is either one facing multiple disciplinary issues, or they are very symptomatic and needing further treatment or further eyes on them. So we will staff them, and that brings up to the key partnerships that we have there. And so I'll touch a little bit on each one of these and also their role in that Mdt meeting. So jail command staff is a huge one, because we can't be making any decisions in regards to housing or in regards to monitoring if the command staff isn't on board. And so they are in there, and that's where they'll be double checking with their policies, with their procedures, if what we are saying can actually match realistically what they're able to do and whether they're on board with doing that. So having jail command staff in there is key. It's also one of those things where when we do these presentations and you do webinars and people talk about how wonderful their programs are, this is one of those pieces to where you get initial funding, you prove your results, and then you can show to the people who run these programs the benefit of that. And once they buy in, it's a lot easier to either expand upon programs or make them more permanent and find permanent sustainability, whether that's for funding or program implementation, which the people who make those calls are in on it. So jail command staff is a huge part of that. We also have jail medical, and so this is not provided by Lords, but we will work with them to help tease out some of where behavioral health issues in addition with the medical. And so jail medical will make sure and let us know that the medication's been taking, or whether it was refused to be taking, whether there is some potential other medical issues that may be interfering with the medication or interfering with the treatment. And so they are able to give us both the medical side and the psychotropic medication compliance issues there. And so they also can make the recommendations if medically the person's compromised, that maybe we need to do a non-mental health furlough, but instead a medical furlough to get whatever treatment they need at a local ED or someplace to get them stabilized medically to come back where we can treat them effectively. We also have the key partnerships with local law enforcement. Go ahead.
I would just, could you clarify the acronym MDT?
Yeah, multidisciplinary team. So sorry if I speak in too many acronyms, go ahead and talk. So if PDP, OPP, any of those kind of stuff that I start saying, yeah, please. So MDT would be multidisciplinary team.
Thank you.
You're welcome. And our local law enforcement. And so we're in a kind of a unique area to where we have county sheriffs for both Benton and Franklin, but we also have within Benton County, we have Prosser, we have the city of West Richland, city of Richland, we have Kennewick, and so there are multiple law enforcement entities that we may be dealing with. And so the benefit of that is we have a big part of our crisis intervention team training, and so we can help get the officers who are patrol officers on the street better equipped to deal with behavioral health emergencies. And so whether that's signs and symptoms and recognizing whether somebody is not just a criminal, instead they are experiencing a behavioral health emergency, what that looks like, how to de-escalate that. So we help with that 40-hour, there's 2 of those a year, and really hit that pretty hard on the diversion options that we have for an individual. And so if the patrol officer has the option, and whether they have one of the True Blood DCRs riding with them or not, they are still equipped with de-escalation skills and also resources on what's out there to divert from the arrest. Now, sometimes arrests are inevitable, and whether that's due to the level of the crime or whether that's due to the compliance by the person, sometimes the arrest is necessary in the officer's mind. And so with that, we stress, okay, so if you couldn't use any of these diversion options that exist, let us know and let booking know that what your concerns were, what you saw. And so even though the arrest was inevitable, you still saw this person experiencing what looked like to be hallucinations. They were responding to auditory hallucinations. They were talking to themselves, whatever they were doing, so that when that person comes in, they're not just flown under the radar, and that we can at least get some stuff right away when they get in there, whether that would be to booking or to the actual Mdt meetings or to the, so whether we can staff that up and have that person be on the radar. Okay. All right. It looks like we're running out of time here, but I will try to speed up just a little bit so we can get to question and answers. And so community correction officer, so DOC, we share quite a bit of their population. So same with them, if they have sanctioned somebody or they were non-compliant and they're bringing somebody in because they feel the need to, that they're at least giving us a heads up that, hey, we brought them in, but when we picked them up, they were seemed to be pretty grandiose, or they seemed to be manic, and so we can flag them as well. NAMI is included in there, and so we like to have the people advocating for them have a voice as well. And so NAMI will bring up questions and concerns. They will bring up things that from an advocacy standpoint that maybe we're not looking at clinically, or what the correction officers aren't looking at, and so they are a weekly participant in those. We also have the chaplaincy, and the chaplains are a big part of that. Faith-based programs, or faith in general, is a huge part of a lot of people's treatment, and it can make a difference. So they are doing groups that are, and we do those in accordance with us as well. And so the chaplaincy will do a group. They will identify certain populations who will do well in those groups, and then we try to piggyback off of that and do evidence-based practices like wellness recovery action planning, so RAP groups, IMR, illness management and recovery groups. So we'll use some elements of those in addition to the chaplaincy to help with more psychoeducational groups within the jail. So we also will work with the courts in general, so judges, prosecutors, both prosecutor and defense, to see whether when we have identified those individuals who are better equipped for some of the diversion programs, that whether the prosecutors and defense are going to be on board with that. And so most are. We're pretty lucky that we have a good relationship with them, that they will hear us out, and they feel strongly that they can voice their opinions, and we will voice ours, and there's usually a pretty good response to where, well, we can try it, or based on the person's non-compliance history, they may decline that. And then we have housing resources. So we try to identify either housing programs that this person will do well with, or whether that's going to be more therapeutic housing. And so whether that may be faith-based or whether we have some group housing, any type of housing, we'll make sure that that is going to be more beneficial or appropriate for that specific person. And then, of course, our behavioral health providers. And so whether we work for Lords, but we're not the only game in town. And so we'll give people the options to either, if they have a current mental health provider that they're seeing, to invite them in because that's who they're going to be released to, or they may have concerns prior to them being that we need to hear about prior to them being arrested. So we can go ahead and with the next slide, part of that, what Gordon touched on with the prescriber in jail. And so in addition to, yes, I don't sleep well when I leave my house in a plush hotel, let alone if it was in jail, other than that, and also blowing up the medical staff's budget, there's some things that we could touch on that not everybody needs medication, and so we'll have notify during those meetings or during the kite system or however those come up on the radar that we'll have our staff go in there and teach sleep hygiene, teach coping skills, teach things that you can use, diversionary activities, things that they can do to help mitigate those anxiety symptoms or having those sleep issues to the best we can without having to just throw meds at it. Not that there's anything wrong. If they truly have a sleep disorder or they truly have an anxiety disorder, we'll work on that. But we'll try to keep those psychotropic medications more for the need more of mood disorders, psychotic disorders, those types. So again, we are also working with our commissioners to get on board for the Step Up initiative. And so what that is, I'll go ahead and read that, is the human toll of this problem and its cost to taxpayers is staggering. Without change, large numbers of people with mental illness will continue to cycle through the criminal justice system, often resulting in tragic outcomes for these individuals and their families. Missed opportunities for connections to treatment, inefficient use of funding, and a failure to improve public safety. So we are trying to get on board and get all the parties and powers that be on board with that, and so that we can really, change our way of thinking when it comes to corrections and inmates treatment. So that's something that we will continually working towards, and it's not a perfect system, and we will keep trying to evolve with it.
Yeah, and I know we've probably...
Gordon, Cameron,
I'll just
oh,
add
no, you guys, go ahead.
I was just going to add one more thing, and I know we're kind of getting into our question and answer time, but I think the key success to any program, and this probably doesn't come as a shock or is any great insight into anybody, but is hiring the right people for those jobs. And obviously, a job in a correctional center with that culture, you have to hire the right individual. And then with that being said, have the right individual train him. And again, I mentioned it earlier, and Cameron probably won't pat himself on the back, but he does an excellent job of training and knowing his audience. And so, when he's trained people, and we trained 184 officers in mental health first aid, and kind of how he framed it to them. And some correctional officers are, social worky and touchy-feely. A lot of them aren't. And again, how he framed it to them is, even if they don't want to go and give the inmates a hug, by doing these certain things, by recognizing signs and symptoms, by knowing what to do and not to do, it will make their job easier, which I think everybody wants their job to be easier. Plus, it'll reduce their liability, which again is a selling point to everybody. If you do the right thing at the right time versus the wrong thing, it reduces your liability. And so I think, thanks to his training, we've gotten buy-in from a large majority of the corrections staff. So, with that being said, we'll field any questions that we have time for.
That's a great segue, because one of the questions was actually, what kind of training do you do with the officers in the jail around triaging, particularly around substance use and behavioral health, and differentiating whether or not whether it's a mental health condition or a substance use condition?
Yeah, and Cameron again can probably speak more in detail about it, but mental health first aid kind of gives a large overview for laypersons on how to identify signs and symptoms. Doesn't try to train them to be mental health professionals, but trains them to how to recognize signs and symptoms, what to do, at that moment, and then who to refer to. I'll let Cameron expand on that, because I don't think we're not that we're not as concerned about teasing out substance use or mental health for them, because even for us who, again, 19 years and 27 years experience, sometimes it's difficult. And again, it's the symptoms you're looking at and the need of the individual. And so we want to address that. And then, at some point in the future, I identify kind of the core cause. But I'll let Cameron talk about the trainings he's provided.
Yeah, very much what Gordon said. We focus on the signs and symptoms in those danger areas, those risk areas, and so to not make it too convoluted for them on whether it is substance use or whether it is mental health or whether it's medical, we show them where their danger areas are at. So if somebody appears to be hallucinating, to them it's not important whether that's due to their meth use or whether that's due to their diagnosis of schizophrenia. They appear to be hallucinating. And so what do you do with somebody who's experiencing auditory and visual hallucinations? We will give them a little bit of insight on the type of hallucination, on maybe that may be more so if somebody has tactile hallucinations, so feeling like things are on their skin, that's going to be typically more drug use than what it would be mental health. And so we'll give them some of those kind of signs and symptoms on how to tease that out. But as far as diagnosing and what to do in the jail setting, they're going to handle whether it's drug-induced or whether it is a true chronic mental illness, they're going to handle it in the same way. And same with the medical emergency. If somebody is shortness of breath, they're grasping at their chest, we don't want them to second guess on whether this is a panic attack and then it turn out to be, something more severe, heart attack, or something that is more medically driven. They're still going to address every situation depending on what they're seeing. And so we really stress here's what to look for. You don't need to put too much focus on whether that is truly a medical emergency or whether it's behavioral health or so on and so on. We'll make sure that they know what to look for and then get the right people involved, whether that is the medical or whether that's mental health. So we try not to get too much in the weeds with them because they don't really respond that well to that either. They're kind of under the, hey, just give me what to look for and what to do, and the other kind of stuff I don't really need to know about. They don't really seem to be overly concerned with being able to diagnose or even wanting to diagnose.
Sounds very holistic and whole person, which is the direction I think that we all want to go into too. Cameron and Gordon, thank you guys so much for putting this together today. What great information. And I know that there are a number of questions, and maybe I'll send those to you and we can send out maybe some responses along with the PowerPoint and the recording link. We are at the end of our time, and I do want to remind folks that our next month's webinar, which will be August 26th, we'll be focusing on therapeutic courts. So we'll be providing an overview of some of the different therapeutic courts and provide some information on that. Again, thank you all so much for your time. Amber, our ASL interpreter, thank you so much for your time today. And again, thank you for your interest in the Behavioral Health and Criminal Justice Interface series. We hope these webinars are helpful. Please feel free to give us feedback on how the information is provided, as well as future webinars that you'd like to see conducted. And so have a great day, everyone. Thank you so much for your time today.
Thank you.
Thank you.